Thank you, Maria. It's a very nice opportunity to be here in your conference. And first of all, my apologies to all the German speakers. I'm German, and I prepared this in English, and I will hold my presentation, give my presentation in English. And I think next time I'm invited to a conference in Switzerland, I'll look better if there's a possibility to speak in German, because it would be also a pleasure. So sorry for that. Closer to the microphone. As we have now slightly changed the order, so some things I wanted to say will be said only, will be said only later by Alexander. He will present our, basically a harm reduction data collection that his group did that involves a lot of the data that we collect at the European Monitoring Center for Drugs and Drug Addiction in Lisbon. We are a specialized EU agency, so one of these decentralized agencies that carry out technical work. So we are supposed to be a team of specialists in this field, and we consist of medical doctors, sociologists, psychologists, lawyers, chemists, policemen, etc. We are about 100 people. And this is the outline for my presentation. I was given the title to speak about new trends. So I'm going to talk about achievements, because yesterday you talked also a lot about opportunities and challenges. I'm going to talk about a bit what has been achieved by harm reduction, what can we see, what can we really document, and what is now for the next years to come, actually, what from our point of view as a data collection agency, the challenges. And I'll tell you that harm reduction is a major policy component, that we have growing evidence base, that we have already reached very good levels of availability and somehow good level of coverage. But on the back of this rides a lot of complacency that we have done good enough and it's actually not important enough anymore to do more, invest more, or develop the skills of the workforce in harm reduction. We see also Europe at two speeds, so not just bluntly east-west, but more or less Central Europe, Western, Southern, Northern Europe are quite different in harm reduction. And I will show you some data on this. And I think also what I want to mention is I see quite a challenge in adapting the work practice to new evidence base. And addressing, now what we also see is that harm reduction work is moving into areas that have been neglected, even including by the workers themselves, because some other problems have answers and some other problems, and this is what Alexander will then describe, I think. Some harms, like drug-related deaths, have no answer. So this is the overview. Now I have to go even quicker. So I'm pointing this to the back, and it doesn't move. Can somebody turn the next page? Okay, so I said all this already. The harm reduction is a major policy component, not only in most of the national drug policies, but also at EU level, which is actually a reflection of the 28 member states' policies discussion in the horizontal drugs group. I'm sorry, we do not collect and present data from Switzerland. Switzerland is the main innovator, has been the main innovator in harm reduction. You have here all the services other countries can be only dreaming of. And I'm sorry if our evidence base, of course, includes what data you provide, and you are fortunately also active in European activities. But when we talk about data, we do not have a single data set from Switzerland in our portfolio. So, but we see in Europe, and I think you see that here in Switzerland too, majority of people with high-risk opioid use are in contact with care, are getting treatment. There's a downward momentum in heroin use, less people entering for heroin use into treatment, and there's a declining trend already since a very long time in the number of new HIV diagnoses in this group. This went down immediately with the introduction of harm reduction. So let's have a look. So until the end of the 90s, we see in the region, in the European region, an increasing availability of core interventions, and that you can see this flattens in the year 2000. So by the year 2000, the bulk of member states had politically embraced and implemented needle exchange and opioid substitution treatment, which we consider as core indicators of harm reduction. So this happened as a political level. the scaling up happened until the end of the 2000s. So the first decade, or from 1995 till 2010, the scale of harm reduction was increased. And you see here, this is the number of cases in opioid substitution treatment reported to us. The blue is the countries who have been members of the EU before, until 2004 already, 15, and the smaller black squares up there is the 12 and now 13 other countries that joined later. This includes Croatia. So you see until 2010, a very neat and fast increase of this. You see also a decline. I'm going to talk about it later, a bit more detail. We have now 1.2 million overall in drug treatment. Of them are mostly in opioid substitution treatment at 730,000. This is 1 in 2 users. And why is it so broadly distributed? Because it's a very effective harm reduction measure. It helps people control their drug use. It helps people get their lives better in order. It helps also to reduce infections and drug-related deaths. It's at least the most researched harm reduction intervention, I think, globally. So we have 2 important trends that have made it possible to treat so many people. That is that the general doctors, the primary healthcare services have got involved in this at some point. It is not provided mainly by low threshold or harm reduction organizations, but also provided by them. We have seen a trend towards lower thresholds, easier access to this treatment. And we see also now increasing number of guidance to improve quality, but the Europe at 2 speeds, and I will show later. Some countries are doing much less than others in this field. So what we also have positively achieved, and includes a lot of work done by European researchers, is that we have more evidence now of harm reduction. We have now, because harm reduction has been implemented over so many decades, 3-4 decades now in our region, we have some, even if no studies have initially been paid and set up, we can use data collected in a monitoring area for conducting analysis, ecological studies, basically. Regions where interventions have not been available can be compared with others where they have been available. This gives us interesting new data. We can also use compiled data sets from different locations to do meta-analysis, and this actually has all strengthened the evidence base, and we know now that it is not enough to provide a single intervention, but that harm reduction works as a component of a number of different interventions. So we have, as one result, our best practice portal. Maybe you know our website. I will later give you the link also. We have a best practice portal that brings together latest evidence on interventions, and we have also been working with our sister agency, the European Center for Disease Control in Stockholm, on a guidance that was published in 2011, where we have brought together the evidence based on what helps us to prevent infectious diseases as a main harm in this field. You can download this stuff from our website. So now I want to talk a bit more about challenges in the remaining minutes I have. So what I've told you earlier is that it was until 2010 that we saw an increase of opioid substitution treatment. And we do now, I have put the moving average trend line on these data points. We see very clearly numbers are receding. We will still report increased numbers of treatment in Europe because the Turkish data set is now joining up our data set at the EMCDDA, and they have really scaled up in Turkey the treatment. So the overall number of cases in our reporting area is increasing because Turkey is, as a member state of our agency, doing a lot more than they have been doing. You see, and I had to magnify it on a scale by 10 there on the right side of this graph, the trend in the new member states, which is mainly Central and Eastern European member states, is actually the same. It's not there where we think, okay, it's low level, but they're still increasing. No, it is also decreasing since in the last 2 reporting years in that region. And in more countries, in some countries more strongly decreasing than in others. And there, surely, we do not have a coverage level of the average 50% of opioid users, and we are looking together with our partners, the focal points in these countries, in making sure the policymakers are aware of the potential risk that this low level of provision of a very important harm reduction measure is posing to their levels of infectious diseases. You know, perhaps the Central European region is one with a very, very low infection level regarding HIV. They do have also hepatitis C, including in some countries higher level. But because of this epidemiological background situation being not very dramatic, it's very hard convincing policymakers. Syringe provision in Europe, it has reached we have not from all countries valid estimates of the number of injecting populations. We actually only have, I think, about 12 countries reporting current estimates. So only for 12 countries where we have syringe data can we produce an estimate of how many people have received how many syringes per year from a subsidized or free syringe exchange program. And we see in most of the countries, this is more than 100 syringes per person in most of those that report, but we have also some countries where the levels are still very low. And in Greece, the levels in Athens are now better, but in the whole of Greece, as we heard yesterday from Effie, it is a lack of services. So the risk assessments we did together with ECDC show there's ongoing HIV risk in about 1/3 of the countries in our region. This is a spaghetti graph. You don't need to be able to see which country is which, but I show you basically what I've done is I've put our data that we collected in the year 2007 for 20 countries on syringes given out by specialized programs and compared the trend. So you can see basically that quite a number of countries have still increased, and partly it's very small numbers we are talking about. But there is also a decreasing trend, not in half, but in less than half of the countries. In some countries, this is explained by the lack of demand in the course of expansion of treatment. Drug users are less asking for syringes. In other countries, we think this is linked to a lack of funding opportunities, or we don't think that we know that from the reports from our country. So what this is meant to basically say is, and I've excluded Greece there because they had a 700% increase of syringe exchange in that country, and would have changed the format of my graph so that you couldn't have seen much. So this is why Greece is not included, but they have increased 700% over these 6 years. I mentioned earlier, we are now worried that the outbreaks that have been happening of HIV in Greece and in Romania since 2011, and they seem to be clear signs of leveling off in Greece, but not the same in Romania. So we are very concerned that the positive trend in Europe of HIV infections among injecting drug users is returning upwards, and it is here visible on the graph. We think in regards to applying new evidence base, we see some progress in the prison field, with more countries now allowing and not only the initiation, the continuation of substitution treatment in prison, but also the initiation. And we see the gap of treatment between community and prisons is closing, but still we have 5 countries who do not at all provide this treatment, and Greece, Cyprus, Lithuania, Slovak Republic, and Turkey are those 5 countries. The through care in the community is also not very smooth and poses a lot of problems for the users. So what we see, harm reduction services are now turning to increasingly, and this is really also a positive sign, is that you are turning your attention more to other issues, especially to hepatitis C, to the prevention of drug-related death, and to the improved information for consumers. That is also, I think, a very important harm reduction measure. So doing this, you face, however, challenges to increase the portfolio of your services, to make sure your staff, your colleagues, yourself, you are trained in providing this. And Yes, and then so new areas like alcohol and tobacco-related harm among the populations you are in contact with. Older, aging drug users have usually a lot of cardiovascular problems. There's also the challenge of including other addictions like gambling addiction and thinking of harm reduction in this field, and making sure you are qualified to respond to sexual health issues and mental health issues among the participants of your services. Because what the research has shown is that the multitude of basically your screening or the people coming in contact with harm reduction services, they get not just a single isolated intervention. They are considered as a case that needs a broader approach and a referral network to other services to provide them with important services beyond these, let's say, syringes or substitution treatment. Now, hepatitis C has been mentioned yesterday as a new challenge, important challenge, and I know that many of the projects in Europe are currently working on this. So the role of harm reduction facilities in this context is quite clear. Because of the need to treat current users, it will be harm reduction facilities who will have to get involved in providing and accompanying this treatment with the hepatologists carrying it out on a medical level. So there are solutions needed. This is a challenge. And we are compiling together with some research teams also evidence and experience on HCV treatments among people who inject, and that obviously includes people who do not stop injecting. We hope that we will publish a book about this in 2015. But I know a number of other projects around here and who are working very hard on making standards and identifying the best practice. So I also mentioned reduction of overdose deaths as a new focus. That's in two directions. Some countries have now finally come back to the idea of opening consumption rooms. Denmark has gone forward last year and Athens as well. And I think there's a presentation of this in the conference. And we have now a very keen interest also in learning more about naloxone. We have the meeting of our legal correspondents in June. We'll look at this topic in an internal session. And we hope in October this year we will have a big meeting in Lisbon that will be made available online, I hope, where we bring together evidence and experience on this. So, my last slide is focusing on these challenges again. And when I thought about this presentation, I realized what is, from my point of view, when I collect harm reduction data for the European region, it's very unsatisfying that less and less countries invest in research on problem drug use. There is, from my point of view, a lack of interest in many regions in Europe to know about what size of populations they're facing. And regarding the use of new drugs, this is actually quite similar, though there we see that this is a phenomenon Adam will later talk about that is not limited to a very small group of marginalized people, absolutely not. So I think an investment, like it was in the 1990s, in a decent research on the epidemiological situation is so important to use the data of how much harm reduction services are provided in order to report to policymakers the level of coverage. So if you do not know how many opiate users or injectors are there, or if you just assume there are less, or we don't have a problem, then you may one day be surprised about an outbreak. And I think we need to remind governments that monitoring is an essential component of policy making. And I think a de-investment in this area would be really a mistake. So these gaps need to be closed. We want to have coverage estimates on the important interventions for the whole region, not just for some countries. And we do not have those at the moment. And I think meaningful, when we are asked to what services should be developed for the new drugs, I think this question is rather simplistic, because new drugs do not require new answers. They are the same old type of interest. People are trying to achieve certain effects by taking certain drugs, and they have always been using stimulant or depressant drugs. So the answers to these types of addictions are the same or very similar. But I think if we wanted to know what new answers we may need for new drugs, we should also very much focus on the community of users of these drugs and try to find the answers together. And I think this was, in the early days of harm reduction in the 90s, one of the main qualities, that the harm reduction people did not isolate themselves. They went to the users and tried to find out what they needed, and they provided services. They provided food, shelter, medical services, consumption rooms. And it was always the characteristic of this approach to drug services that was very close to the users. And I think this is also what makes this group of harm reduction professionals the best partner in finding out what we need to develop for the users of today. So thank you very much. For this, I will point you to some products. We are organizing a summer school this year again, and you can take part in it. There's still some spaces free. You find everything on our website. The website is down on the bottom of this slide. Thank you for your attention.